Hi, I'm Kari Stephens. I'm a clinical psychologist at the University of Washington.
And I'm Patrick Raue, also a clinical psychologist at the University of Washington.
And today we're going to talk to you about dialectical behavior therapy distress tolerance skills.
And here are our learning objectives for today. After this training, we hope that you'll be able to determine when to use DBT's distress tolerance skills with your cases, to list some distress tolerance skills, and thirdly, to integrate use of distress tolerance skills into your practice.
So today we're going to start with a case example that helps illustrate a patient who has experienced chronic pain and has had elevated depressive and anxiety symptoms that started after his pain started. The case is going to illustrate how emotional distress arose from his pain flare-ups and how the distress has interfered with the successful treatment of his pain and with his day-to-day functioning. This case is going to allow us to describe the distress tolerance strategies as an evidence-based behavioral approach that can help reduce intense distress and improve his overall functioning. So this is a 40-year-old Asian man, a father of one, whose child is age 12. He was a laborer. He's been unable to work since his pain began after he had a work injury that affected his back. His key complaints have been, my back hurts, I keep overdoing it, and then I wind up where I started. He said, I'm worried that things will happen to my family if I don't get better soon. He also said that he yells too much at his son since he stopped working, and this bothers him quite a bit. His average pain rating has been a 5 out of 10. And he said it spikes to a 10 when he tends to overdo it. He also reported mild depressive and anxiety symptoms that began after the pain onset, with a baseline depressive symptom measure of the PHQ-9 out of 10 and a baseline measure of anxiety of 11. So we want you to keep this case in mind as we move through these different skills.
So to use these skills, they're really only appropriate for when patients are experiencing some kind of crisis. So let's talk about what a crisis is. A crisis is when you have a serious problem, but you can't solve it. If you could solve it, you would. In a crisis, there is pressure to solve the problem, but it's really difficult to stop trying to solve the problem. And emotions are really high and distressing, and they tend to make everything worse. A crisis is a short-term situation. If it's happening all the time, we don't call it a crisis. It's a chronically stressful life. So let's think about our case. He's somebody who can't work. He's not getting paid. This is a chronically stressful situation, and that by itself does not represent an immediate crisis. Pain flares, however, would be an immediate crisis for our patient. Now, distress tolerance was originally developed as a skill to help treat borderline personality disorder and crises that come up for patients who have really intense and frequent emotional distress, and that can sometimes lead patients to feel suicidal. When we think about chronic pain patients, intense pain flares can also become a crisis. And in these cases, our distress tolerance skills can be very useful strategies. So to continue with our definition of a crisis, if you can solve it, then you would. If you can't solve it, then we consider it a crisis, and we encourage patients to stop trying to solve the crisis. If patients continue that can make the situation worse and make the emotional experience worse and more distressing. So we encourage patients to focus on distress tolerance skills if there's a crisis that can't be solved at the moment. So an example for pain flare-ups is that we encourage patients to start by problem solving if it can be solved. So for example, using hot and cold packs, taking their medications appropriately, potentially laying down. But if they're still hurting and those problem-solving skills are not working, then distress tolerance skills can be helpful.
So one thing we recommend is that we always use the skills ourselves that we teach to patients. So I want to lay out how these distress tolerance skills are not just for patients in these many ways you see here, but also for clinicians. So when we look at patients, they may face many stressors, but we may also face many stressors. So patients, while they may be dealing with pain flares or frustrations with their care and all the things you see on the list here, as clinicians, we may also want to use distress tolerance skills for all of the stressors we face, like having large caseloads, having difficult and sick patients, hearing many traumatic stories that can be really hard to hear throughout the day, that have lasting effects on us, the inability to help our patients sometimes, where resources are very slim or we just don't have enough time packed into the day to do all the things we want. We may have a lack of resources available in the community. We may have frustrating interactions. Lots and lots of things get to all of us that become problems we can't solve, as Patrick said. So we want to use these distress tolerance skills not just for our patients, but for ourselves as well. When we move from a mindset of problem solving to one of using distress tolerance, we have to change our goal. Usually the goal with problem solving is to fix something, to make it better. But with distress tolerance, it's really about surviving without making the situation worse. So the new goal becomes don't make things worse, as opposed to make things better or fix them. So we can't expect that distress tolerance skills are necessarily going to result in us feeling better. We have to instead look for potentially just not making things worse. So the fact is that you often may feel better, but that's not the purpose of the skill with this particular set of skills that you're going to use with patients. So the last piece here is don't stop. If the skills prevent this crisis from getting worse, but they don't make you feel better, don't stop using them. This can often be the hardest thing to convince a patient around. And even the first time I often talk to a patient about using these skills, they forget that the goal is actually to not make the situation worse and come back in and let me know that they didn't feel better, especially with pain.
So as Kari said, the goal in these cases is not to make the crisis worse. Here are some examples of how you and your patients can make a crisis worse. So think particularly about pain patients and pain flare-ups that in these cases somebody might respond by not taking care of themselves, eating too much, eating too little, laying down for too long and isolating oneself, getting irritable and yelling at someone, potentially using drugs or alcohol. In other cases, you can make a crisis worse by what we call retail therapy with money you can't afford, complaining so much that people don't want to spend time with you or talk to you, or giving up on leading your life in different ways.
So as we use distress tolerance skills, we basically get to survive and live to fight another day with our crisis. We don't get taken down by it. And the more we learn to tolerate crises without making them worse, the more competent and confident we become being able to handle them as we move forward.
Okay, so we're going to talk about distress tolerance in 4 easy steps. In our first step, we do an assessment. In our second, we really explain distress tolerance skills to patients so they understand it and they're on board. In the third step, we look at what's a relevant practice or homework assignment for patients. And in step 4, we do a follow-up to evaluate the outcome. So let's start with step 1, and we're going to give you 3 questions to do a good assessment. The first question to ask is, what triggers the distress? What caused the patient to feel distressed? And here we want to be really behavioral. What did the patient do or not do? Did they talk with a family member? Were they looking at mail, for example? Were they thinking about a certain thought or ruminating? The second question is, how did the patient respond to that trigger? What did he or she do while they were distressed? And here again, we want to be really behavioral and concrete. Some examples could be they responded by yelling or starting a fight, or they went to their room and isolated themselves and ruminated more, or they laid in their bed all day, or they used substances, or maybe they avoided some important tasks. Here we want to listen for both helpful responses, what they did that was skillful and helped with the problem and the distress tolerance, and what was not helpful, what was destructive or made the situation worse. Third question is, how did the patient's response make things worse? And here it's really important to get the patient's perspective on that, not yours or somebody else's perspective.
So let's go back now and think about our case again, as Patrick just said and laid out nicely those three different questions that are going to give us a sense of the trigger, of the response to the distress, and the sense of what made it worse. So with our case, his triggers really were intense pain flares that he had for hours, that he said typically happened after he overdid a lot of activity. He said that generally what happened after he experienced a bad pain flare is that he would become bedbound. He'd lay down for a very long time. He didn't eat generally or drink things, and he stayed by himself. And when his son would come in and interrupt that time, he'd often yell at him. So here's the key part. I think it's pretty straightforward to find out what might have happened that started the distress and to get a good sense of what happened after the distress started. But really at this point, you need to then ask, what made it worse? And when we asked our case, he said, I feel so guilty after I yell at my son. He's only 12 years old. And that really was the motivator for him, not necessarily laying in bed, not ruminating, not eating or drinking. So it might be tempting for us to go after those particular symptoms, but really we have to track on what he said made the situation worse first. Once you have those three questions answered and your assessment is pretty solid, you want to move on quickly to then explaining the concept of distress tolerance and making that pitch in a really compelling way to your patient.
When giving the pitch to patients, we want to explain what distress tolerance is. For example, these are skills to help you with fill in the blank for what the patient's specific triggers are. And you've told me that you tend to fill in the blank with how the patient responds to these triggers. Then we move on to explaining the goal to patients. Again, the goal is to not make things worse. And this is very different from feeling better. Our goal is to bring down your emotions so that you can think more clearly. You've told me that things get worse when you, and fill in the blank based on what the patient has said about how he or she makes the situation worse.
So based on what Patrick just said as a great template for how we can explain distress tolerance and get that buy-in from our patients, let me walk you through how we would do that with our case. So to first explain this to him, what I would say is these skills are here to help you with the intense pain flares that you've been experiencing. And you've told me that when you have those big pain flares, you tend to stay in bed for a long time. You often don't eat or drink. You get pretty isolated and you yell at your son. So really, I want you to know that the goal of these skills that we're going to talk about here are to not make that situation worse. It's not necessarily that these skills are going to take your pain away or have you feel better, but they're going to help you from making the situation worse over time. And really, the target here is going to be to help you have bring down those emotions so that you can think more clearly when you're having that pain flare. And remember that you told me the things that make you the most worse during that time is really yelling at your son. So I think we want to target these skills towards helping you with that especially.
Okay, so we've just done our assessment, figuring out what the triggers are, and we've explained the concept of distress tolerance to our patient. And keep in mind that these are pretty brief steps. They only take a couple of minutes, and that lets us save the bulk of our time with patients for step 3. And that's where we determined what are the skills that they'd like to try out using and think through some situations where they can practice them. So let's talk about what are the distress tolerance skills. There are 3 broad categories. The first category is distraction skills. The second is ways for patients to soothe themselves. And the third is skills to help them improve the moment. And we're going to review a number of the strategies within each category next.
So let's first start with what the distraction skills are. In dialectical behavior therapy, there are many acronyms, and with this, we use these as memory aids to help us remember what all these skills are. And what we like to say with distraction in distress tolerance is that the wise mind accepts. And accepts is our acronym here to give us lots of thoughts on what are different ways a patient can use distraction. So the first is really using activities. That's pretty straightforward. The idea here is that you can go and do different activities that take your mind off whatever the crisis is. The second is about contributing. Contributing is the idea, it can be an activity in and of itself, but the idea is that you go outside yourself and ask somebody else how they're doing in some way, or do an activity that actually contributes to the well-being of somebody else to get your mind off your own distress. The third is comparisons. So comparing your life to how it might have been before and how this may not be as bad as that point, or comparing yourself on the outside to some other situation or other person that might be worse than your own situation. Comparisons can often be a really wonderful way to sort of get perspective on what you're going through now. Using opposite emotions is a common skill in DBT in general. The idea here is that when you get distressed, there are one or two negative emotions that tend to dominate the scene for you. So figure out an emotion from the negative one that you're feeling and try to bring it on. So if you're angry, watch a comedy. If you're scared, watch someone that's daring. If you're sad, listen to some upbeat music. So pick an opposite emotion that you can go invoke. The pushing away is really the idea that you're deciding that this is something that can't be dealt with right now and put it out of your mind. Push it away, literally, and just imagine yourself putting it on a shelf and come back to it later. Thoughts is another way that we use distraction. So the idea is when you're in a crisis that you can't solve, often our minds are stuck on thinking about that crisis over and over. But if you can fill your brain with other thoughts, there's no room for that crisis to continue to be in there. So singing songs to lyrics you don't quite remember, or counting backwards by some high number by a factor of 7 that makes you have to think about it, are often quick ways that you can use to fill your mind with other kinds of thoughts. Sensations is the best strategy to get unstuck when you're feeling very distressed. When you mobilize your body and bring your mind and emotions with it, you can put your face in cold ice water or hold on to ice. You can run up and down stairs, take cold showers. Oftentimes, patients with chronic pain have limitations in the kinds of things they can do. So using sensations as a way to sort of shock the system into distraction can be really useful.
The first question to ask is, what triggers the distress? What caused the patient to feel distressed? And here we want to be really behavioral. What did the patient do or not do? Did they talk with a family member? Were they looking at mail, for example? Were they thinking about a certain thought or ruminating? The second question is, how did the patient respond to that trigger? What did he or she do while they were distressed? And here again, we want to be really behavioral and concrete. Some examples could be they responded by yelling or starting a fight, or they went to their room and isolated themselves and ruminated more, or they laid in their bed all day, or they used substances, or maybe they avoided some important tasks. Here we want to listen for both helpful responses, what they did that was skillful and helped with the problem and the distress tolerance, and what was not helpful, what was destructive or made the situation worse. Third question is, how did the patient's response make things worse? And here it's really important to get the patient's perspective on that, not yours or somebody else's perspective. Our second broad category of distress tolerance skills are self-soothing skills. And sometimes these skills can be really hard for patients with chronic pain to think about using for themselves. To facilitate the brainstorming process, it can be helpful to ask them what they would do if they had a loved one going through a similar crisis, and how they would recommend that that loved one kind of soothe themselves, or how they can be helpful to their loved one. And that's exactly the kind of activities that we want to encourage patients to do for themselves. We encourage them not to make the situation more difficult or be more uncomfortable than is required for them to be. And a good example to kind of think about this is that we wouldn't want to have somebody wear tight shoes if they're going to the dentist, and that's a rough experience for them. So generally, when we self-soothe, we can think about ways to do that with our 5 senses, and we can help patients to brainstorm ways to do this in all of their senses. So just think about the visual sense, that they can be encouraged to decorate their homes or their spaces in pleasing ways. And again, we as clinicians can think about the same ways to soothe ourselves. It's always helpful to think about ways that we can use these skills as well. And you'll see a lot of different examples for the other five senses: sound, smell, touch, and taste. I think the idea is to really help patients see the range of different ways that they can soothe themselves.
Okay, let's cover the last part of the distress tolerance skills, which are about improving the moment. So we are back again to helpful acronyms that help us remember that skills to accept pain and reduce suffering are really about improving the moment, or seeing all of these different skills here. So let me go through each one by one. The first is imagery. And you can use imagery with a patient that has chronic pain or a patient that's in crisis by planning ahead of time to have some way to image in their own mind, or even look at images that help invoke that image, that usually tend to involve something like feeling happy or safe or some kind of relief or being relaxed. Those are generally the kinds of imagery that are the most helpful. Patients can also find meaning in what they're going through, as can we as clinicians. So finding some kind of deep sense of meaning about why we're going through what we're going through can often help us get through it in a skillful way. Prayer is another useful skill. Prayer is not necessarily meant to be a religious skill. We can also say serenity prayers to ourselves, regardless of what our religious background. Things that can mean this too shall pass. I can get through this as well. Relaxation is a pretty straightforward explanatory skill that we can use. We can do this in brief bursts where we can clench for 5 seconds and then release for 5 seconds. This can be really helpful in our own clinical practice before we see that patient that we're really dreading or is feeling like it's going to be really difficult. And you can do full-on progressive muscle relaxation that's really helpful with chronic pain as well with a patient. Doing one thing in the moment is really about the fact that distress is usually not in the present. It's usually in the past in some way or in some anticipated future event. So doing one thing in the moment mindfully and sort of bringing yourself to this present moment can be a way to sort of get some release from what that crisis is about. Taking a vacation is not literal. It's really more of taking a vacation in your own mind. And the idea here is that you sort of deliberately step away from something and do something a little more relaxing or fun or peaceful in that moment, even though you know you've got this crisis going on. Keep in mind, a vacation is not something you don't ever return from, right? If you don't return from a vacation, that's not a vacation. That's really running away. So you want to make sure if you do that, that's in a time-limited way. And then the last one is using encouragement. So the idea here is not to be Pollyanna, but write down or remember sort of things that we would say to ourselves to encourage ourselves that we can get through something. And again, one thing we haven't mentioned, Patrick and I, yet, is that it's really useful to do a lot of this planning ahead of time and plan for this before you're in the crisis so that you have a bit of a strategy. Okay, so let's look back at our case again and think about what CR was telling us was his crisis. So at the end of the day, he tends to have a pain flare, probably due to all the activity that he's doing, overdoing it during the day. So making a specific plan is important, and he can plan to use these strategies in the evening when he typically both experiences a pain flare and most frequently starts to yell at his son. Remember earlier we said that yelling at his son is going to be the primary issue that we're going to want to address because that's the one that's most important to him. It's common to combine various skills together, so especially when a crisis lasts for more than a few minutes, which often is the case with a pain flare. So here, CR is going to combine several skills that are going to include using distraction, so potentially watching a movie, listening to music. He's going to lay down with self-soothing, and to improve the moment, he's going to take a mini break from parenting. He's going to spend some quality time with his son, he's going to relax, and he's going to breathe deep. So sometimes parents have a hard time thinking about watching a movie with their child, especially when they're in pain, and feel like a failure that this is them not being engaged. But here we want to really reframe that for him and talk about this is when you're taking a break from parenting. You get to just go have some fun. let your son watch a movie with you, lay down while you're doing it, relax, try to breathe deep while you're doing it, and then hopefully that'll stave off any of the yelling and arguing they'll have.
Okay, so let's move on to our fourth and final step, and this is where we follow up with patients about how their efforts went so that they get some feedback from us and we can help them problem solve any barriers. So at the beginning of our follow-up session, we want to always ask about the homework assignment at these meetings. If patients were successful, we want to really reinforce their efforts and the impact that they had on our goal, which remember was not to make the situation worse. However, it's really important to expect that patients might not have done their practice or their homework. It's really common, especially on the first try, that they won't have done the homework or maybe it didn't go so well. We don't want to be discouraged about that, and we don't want our patients to be discouraged. We don't want to judge that. We do, if something was difficult, here's 3 questions that we encourage you to ask. Was it something about the buy-in to treatment that the patient, didn't have? Did they simply forget to try the homework out? Or did they try the plan, but it just didn't meet the goal of not making the situation worse? And this helps us to kind of problem solve and redouble our efforts.
So as Patrick said, as you go through those 3 different questions in your own mind for why they might have stumbled through the homework, one of them is really the idea of, do they have buy-in to doing this or not? And that's where this pros and cons skill comes in. So if your patient has a lot of ambivalence about using this skill and feels like it may not be as useful as we believe that it would be useful, it can be helpful to walk them through this strategy of dealing with ambivalence. And so the idea here is you've got a matrix, you've got the pros and cons along the top, and then on the rows you've got, here's what would happen, pros and cons, if by making it worse, in other words, if he continued to yell at his son, then this is what the pros would be, this is what the cons would be. But by tolerating the distress and trying out the distress tolerance skills, here's what the pros and cons would be. So let's look at the case. So with CR, what he told us is that he tends to be in bed and isolating when his son comes up and disrupts him. And that's when he tends to be the most vulnerable for yelling at his son because his pain is so intense and high. So making it worse is continuing that same behavior. And the pros of that is that he won't have to be around others and try to control his temper in any kind of way. But the cons are that not being there for he won't be there for his son and his wife. He's staying isolated from his family. He won't get support from others while he's feeling in pain. And he sort of puts his life on hold. He sort of spends those evenings completely isolated and withdrawn from everybody. Tolerating the distress, however, by trying those distress tolerance skills that we laid out earlier, using distracting with activities, self-soothing, and improving the moment. The pros of doing that may be that his emotions would go down and fall sort of back into the background, and he might have quality time with his son watching that movie, and that life would continue, and he won't seem so removed from everybody else. The cons are that he may get more frustrated on top of hurting, right? It might not go well. He might actually still get in an argument in some way, and his temper may still be an issue. So you can see how he's really fighting potentially the pros and the cons of doing that. And this is true for any patient who's trying to use distress tolerance. So using this skill can really help them get clear on what's driving that ambivalence, and then hopefully help them make that decision to try to commit towards trying the skill in some small way.
Okay, so now we have some additional tips for you when thinking about how to work with patients and encourage them to use distress tolerance skills or to resolve any ambivalence that they may have about using them. First of all, we want to make sure that the particular distress tolerance skill that the patient has chosen is close to the intensity of the distress that they're experiencing. So here's sort of an obvious example. If the patient is having really strong urges to die, it's obvious that doing something like ironing is probably not going to really help. So we want to really bump up the particular distress tolerance skill that they're trying out. Secondly, we want to make sure that the timing of the skill matches the situation. So some examples, distracting with sensations is a really great way to get started, but these are skills that don't last very long. So if you have a patient whose crisis is more long-lasting, we really want to pair those skills with longer-term activities or ways that they can contribute to the situation or other people. Another example is that distracting with thoughts may last for as little as minutes or potentially as long as an hour. These distraction skills are good for if the patient is on the bus, or they're stuck in traffic, or they're in meetings, or they're in line at the DMV. And lastly, taking a vacation is a really good skill to use, but we want to keep in mind that if you've got to get back to the real world, you should only use that for as long as you can.
A couple other tips to add to Patrick's are that any distress tolerance skills overused can make things worse. So we don't want to overuse things like soothing by taste. In other words, we could become compulsive at eating. We could gain weight by eating too much. We might take too many vacations. It might become avoidance in that way, and you don't get anything done. You might distract too much by watching too much TV, etc. So the idea here is that use it as a distress tolerance skill to help manage that crisis, but don't overuse it in your life. Another tip is avoid distraction when it is avoidance. So often people see distraction, getting your mind off of it, as really the only way to cope, and you can't do anything about the problem. So it's important to find out if patients generally tend to only use avoidance, add in some other distress tolerance skills that can make that a more rich menu of options. Sometimes you need to stay with the problem, such as staying in class, or for us, going in and seeing that patient anyway, even though we're tired or we're dreading it, or staying on at work, or with your children potentially when they're driving us crazy. And then be sure to learn self-soothing and improve as much as distract when avoidance is really a big key.
Okay, so those are the dialectic behavior therapy distress tolerance skills. These are not new ideas that we're talking about today. We've just sort of conceptualized and organized them in a more systematic way in thinking about how they can be beneficial in your chronic pain patients.
Patrick and I would like to thank you very much for listening today.